just wanted to thank Vision RT and the SGRT community for inviting us to speak today. I've been attending these meetings for the last 4 years and really taking things back to the team. But this year we've been able to bring some therapists with us as well. So really helping us kind of leapfrog and bring some of the technology back to the clinic. I'm Dr. Desab, the medical director and radiation oncologist at Kelsey-Seybold. And
I'm Elise. I'm the lead therapist.
And so what we want to do is share our experience on how, as you've heard in the first two talks, really having a team approach to getting this technology implemented in a clinic setting. So kind of want to thank Vision RT for some travel funding for us to attend this meeting. And start by telling you a little bit about Kelsey-Seybold Cancer Center. Kelsey-Seybold is a multidisciplinary clinic. We're celebrating our 70th year in Houston. We have 23 locations around the Houston area, but we have two cancer centers, one in the medical center and then one on the north side of town. Prior to 4 years ago, we didn't have any radiation services, so all the radiation services were sent out to our partner hospitals and community centers. And in 2015, we actually added radiation therapy. Kelsey is one of the first accountable care organizations in the United States, and we are accredited by QLPI and the American College of Surgeons. You know, before we get started, I really want to thank the team. I don't even think we got everyone in this picture last week, but busy treating. But you know, we're going to go through some of the struggles and challenges we went through, but I really appreciate the team working with the whole group. And, you know, I'm very proud of the team, all the way from the front desk, all the way to the back where the Linacs are. Everyone really plays an important role in any patient care, and having a patient-centered program really allows us to provide that best care for them. So, like I mentioned earlier, we opened in 2015, March, started with a TrueBeam with Align RT, and really weren't sure what the volume was going to be. So we thought maybe 10, 15 patients to start with. And so we, rather than putting a dedicated SIM in, we had a PET CT as a shared resource, which was nice. So we only had it half a day, but it came with a smaller bore size. So some of the struggles came from that. Prior to opening the clinic, 3 of us actually went to Baltimore for Vision RT training. So a manager who was a therapist, our head physics, and myself went. Typically just get 2 credits, but I wanted to attend as well, because I said, you know, if I'm going to be prescribing this therapy or being part of this team, I want to know where it can be used and when it can't be used. I think some of the talks yesterday and today said, you know, that the technology's there, and then they had to have the doctor to buy in. I want to be part of that early buy-in process. And the other thing, I didn't want to be going to Astro or coming to these meetings and saying, hey, I saw this great thing, let's start doing this in the clinic also. So really having that team was really important. We learned a lot of the basics of the system, kind of saw, hey, this is great for breast, maybe for our SBRT, SRS patients. But when we trained on a plastic mannequin, right? So it seemed great, it was wonderful. But when you come back to the clinic with patients being able to move around and, you know, floppy patients like the first talk, it's a little bit more challenging. So we realized that training was great, but we definitely needed to get things on board back home. It's a good problem. The Cancer Center was very excited. We were treating 45 patients in 2 months. So they were very excited, you know, outperformed their performa for year 1. Bad days, long days, difficult to implement technology. You know, we were there 10, 12-hour days. Breast setups were an issue because we were using that small bore in PET CT. So a lot of times that had to be slide boarded over, cutting off some of the breast, kind of just made it work. So we ended up rather using the breast board. We used a breast board with our arm shuttle on top of it and kind of made them fit through the system. So by having a poor SIM setup means you're probably going to have a poor treatment setup. So we had a lot of difficulties with setting up patients. So we said, why don't we start daily KVing these patients, because that's going to give us some more information on, you know, how to get these patients aligned properly. And then we were like, well, we went to Align RT training. Why don't we start using this? So we started using it, and some patients it worked, some patients it didn't work on. So we were like, well, maybe this isn't the right solution. We were very busy, so we said, all right, let's go back to KV breast because we know that works. Nice thing, leadership 3 months later said, well, we know you're busy. You're outperforming what you're supposed to do. Let's buy you a second linear accelerator. So very happy, right? But with that, we said, well, let's go from a TrueBeam and put an edge in so we can do some more radiosurgery. Good thing is shorter days, but we doubled up the staff, right? So in Texas and in Houston, there's not a lot of TrueBeam, so a lot of therapists don't come with TrueBeam training. So we had to take a step back and say, let's focus on the fundamentals before we start doing Align RT, before we do some of the other technology. And with this, we also got a wide bore CT, so that helps solve some of our problems as well. Just to go over the model at Kelsey, we don't have a very large team. We have a 6-therapist model, 2 on each machine and 2 in sim, and when the sim's not busy, those 2 therapists rotate back to the machine to help with chart checks and offset the other therapists, things like that. So we also have an MA for bladder scanner because we're really important on quality. And so we don't have a large footprint as far as a lot of physicists, a lot of dosimetrists, a lot of physicians. We have 2 physicists, 2 dosimetrists, and 6 therapists right now. So really, how do we implement technology with such a busy clinic? So what we did is we said, well, one of our goals was breast. We weren't so excited about it. Let's go back to our SBRT patients and let's just capture a reference and monitor the patient. We saw, hey, this really works, you know? So we said, okay, the system works. It's probably something that we didn't learn or maybe we didn't catch on in our initial training, both at Baltimore and on site. So we said, let's regroup and let's figure out how we can really use Align RT in our clinic. So I had goals of, breast treatments. I think that's the number one easy indication for Align RT. We want to do more advanced treatments like DIBH. We knew SRS, SBRT could be useful from attending all these meetings and being on SGRT.org. We see patients and centers doing it. So we said, hey, why can't we do this? We knew sometimes we have extended field patients with like a para-aortic cervix or a long lung field. And we have some difficult setups at those patients with just imaging, some extremity patients like we heard about earlier. And so now we're basically using SGRT on the majority of our patients. And we talked about tattoo-less setups about 6 months ago, and Elise and I were both kind of like, well, not sure if we're going to be able to do this. But just talking last night at the reception after hearing some of these talks, we're like, hey, this isn't so bad. We can see how other clinics are really implementing it. So that's one of our goals when we go back. So just like on the first talk, we really said, let's get a team together to implement this technology. So we identified one key player in every section. So as a physician, I said, okay, I know when I want to use it, and I know what treatment procedures we should use. We got a physics team to make sure, hey, let's double check the system. It wasn't working great initially. Make sure the system's working fine. Help us with troubleshooting patients, dosimetry, how do they send plans from Eclipse to Align RT, and then really getting therapists. So we had Elise as our champion from therapy because she had previous experience with Align RT.
Yeah, so I was at another center in Texas who had the Align RT system, and unfortunately we weren't able to use it to its full potential there. We didn't have the gating interface. So basically we were just using it for setup and monitoring. So when I came to Kelsey, I was able to see the full potential of Align RT and utilize it to its full potential.
So what we did is we came up with some goals, like we said earlier, and then we did a site visit to Denver. And so we had a great time at Centura and got to meet with Mike Telheimer, the physicist and the therapist and dosimetry team. And we saw, hey, this is easy. We can use it on breast patients. We saw them do DIBH patients and really got to leapfrog and say, okay, this is doable. We've seen a couple examples, learned a little bit more about ROIs, got the team to collaborate with their counterparts, and we even learned some extra stuff that we weren't really there for Align RT, but it was great. It was great collaboration. So
we had to bring what we learned back to Kelsey. We had to introduce this system to our team. Of course, therapists at first were really resistant to change, but we really had to sell this product and show them like the true benefits, how the quick it assists with the setup, the gating the beam, and monitoring the patient. If you have this ability to monitor the patient and know that you are treating that patient accurately throughout their treatment, that makes us therapists feel great. So our team was ready to jump on board after introducing the system.
Yeah, so what we did is we came in and had a meeting with the entire staff and said, this is what we want to do. But then we did also have some challenges that we had to overcome.
Yeah, so, we didn't learn this technology in school. This is a new technology. It would change our workflow. What we did was working. What's this saying? Why fix it if it's not broken? So we were really hesitant, resistant, skeptical at first. We were so busy at the time. We didn't have time to learn this new system. And also with the staff turnover at that time, we were really focusing on training the new therapist on the machine rather than the new technology we had. So there were some challenges when we were trying to implement the Align RT.
Absolutely. So we went from 40 patients up to 55 patients a day. So that second linear accelerator didn't split the volume. It only added volume to the clinic. So we started with, let's go back and learn the fundamentals of the system. What do we learn in Baltimore, and how do we get that back to our therapists? So I think the first thing we learned is our ROIs was the biggest problem. So as we've learned throughout the last few days, it's all about ROI, right? Telling the system what you want it to monitor and what are you looking at. So once we had the team really gain trust in the system, we were able to understand different regions of interest. What are you telling the cameras to monitor? What's the best placement? And Elise can talk a little bit more about these ROIs.
Yes. So when the on-site trainers came out, they gave us this reference guide that we didn't initially have. And that was very useful for us therapists to refer back to when we were drawing these ROIs. And the most important thing is to make time in your department to have the whole staff in training draw these ROIs, pull out that booklet, talk about all the different ROIs and the right places to place them.
And so the booklet's great. I actually picked a couple up at the last meeting. It tells you what to include, what not to include, kind of as a standard for every patient, or standard, but every patient's going to be a little bit different, right? So, in one of the examples, it says to include the eyebrows for SRS. Just recently, we had this guy with massive eyebrows, just all over the place.
I mean,
so
they're
out there. So, well, sure, the booklet says it, but he's not moving, but his eyebrows are all over the place, right? So you got to crop that out, right? So you still got to customize these standard ROIs for your patient. And so just using this as example, this was one of our initial patients, and you can see that just an ROI was kind of slapped right across the patient. Let me see if the video works. Let's see, yeah. And so you can see that it's going in and out in red, but we know the patient's not moving. They're in the big SBRT bag. And so we actually had to open up the threshold because the patient's on the table, and we're like, well, we don't really need to gate when we don't really think the patient's moving. We didn't stop. We should have stopped and actually edited the ROI, but we didn't. But the next day, we edited the ROI, and you saw it like in the first presentation. If you can crop out that big belly that breathes in and out, see if the video works. We're still in tolerance. Didn't need to open that up, and we know that's just probably natural breathing and not really the patient moving. So once the team learned about these concepts that, hey, this ROI is very important, you can't just slap something on, put it on right before the patient gets on the table, really add it part of their first chart check, this really helped our workflow and really helping the system. One of the things we did with the team is saying, there are different thresholds per site. If we're doing radiosurgery, sure, we want to have sub-millimeter accuracy, right? We're doing a high dose to a very small field. But if breast, the tolerances are 3 millimeters. If you think about it, 5-10 years ago, everything was a clinical setup for breast, right? We didn't really image. You draw some marks on them every Friday. You take images and see where you're doing. And we really showed the group that, the cube doesn't move in morning warm-up, right? But you still see a little bit of flicker. That's probably related to how the ROI was drawn. And yesterday we learned about this frame rate from Caleb's presentation. If the frame rate's low, maybe that ROI is too big, right? So maybe that's why we're having certain issues within the clinic as well. Oops. And so go ahead.
So our plan for the implementation, we're just going to start by using the Align RT for setup. And this is for our breast patients. So set up using the Align RT, take those KVs, since that's what we were used to doing, document those daily shifts, review those trends so we can start gaining the trust in the software so the software can prove itself. And then also identify a list of patients that it's not working so well on.
So like in the first talk, we regrouped two weeks later. And the feedback we got was, well, we didn't know we had to use that. We're busy. We're up to 55 patients. And so the best way to solve it is for me to put that in the prescription. If it's in the prescription, you have to use it.
We had to use it.
So 2 weeks later,
So since it was on this prescription, we had to use it. Thank you for doing that, because that really pushed us to using this software. So we went back to our plan, used the Align RT for the setup, documented those shifts, saw that they were insignificant, and we compiled the list of patients so we could address when the trainers came back.
So it is after having some more comfort with the system, gaining a little bit of trust in the system, we brought our trainers back out, and I know Caleb's in the back, and I know his boss is here, so we'll definitely give you a great shout out. But Caleb's been great, you know. He really helped the team get us to where we're at, really retrained some of the new staff, and like we said, we're a busy clinic, so we didn't have an hour or two to dedicate to training, even though Caleb was willing to stay after hours. Therapist didn't want to stay after hours. So what we did is we said, let's see the patients that it's working on, and Caleb can give us some feedback on those patients. And then the list of patients they said, hey, it's not working on, let's troubleshoot them. Was it an ROI issue? Is it patient habitus? Or is it just it's not the ideal patient to use the system on?
And we also learn how to use the treatment capture feature. So you're looking at the whole body instead of just the ROI. So utilizing that treatment capture was really helpful to get the patients aligned. Yeah.
Okay. So over those 2 or 3 weeks, the team felt very comfortable with the system. We changed our workflow to be all breast patients are set up with Align RT and just a weekly MV port. And understood, you know, there might be a patient or two that might not be ideal for the system, and for those we can still image. And so one of the things we're really big on at Kelsey is following national guidelines. This is the National Comprehensive Cancer Network guidelines. These guidelines just came out about 1.5 years ago, but they've been out for medical oncology in general practice. So they say, what are the indications for different disease sites? What are the indications for treatment for radiation, chemo, hormonal therapy? But they just came out with radiation guidelines from NCCN. And so I took a screenshot of breast guidelines. So they say, and that little purple box at the bottom, I blew that up to the top, and it says, verification of daily setup consistency is done with weekly imaging. In certain circumstances, more frequent imaging may be appropriate, but routine daily imaging is not recommended. So we felt very comfortable that we've moved our clinic from daily KVs to following national standard guidelines, right? And so I think that's very important. But if we're not imaging every day, and if I remember when I was a resident early in my practice, you know, every Friday we'd be like, oh, doc, there's too much lung, not enough lung. Well, let's move the table up, down, side, or whatever y'all used to do. And well, I was like, well, that's great on Fridays. We definitely knew we were treating the patient right. But what about Monday through Thursday when we aren't imaging, right? And so using Align RT and using Surface, I think we feel comfortable that every day of the week we're really treating the patient appropriately for only weekly imaging, right, and following national guidelines. And I really think over the next year, I think Surface Guided will become part of the standard of national NCCN guidelines, saying that we should use a DIBH technique for our left-sided breast. So I'm really glad that our clinic is following these guidelines rather than imaging daily. And so we're really big on policies, procedures at Kelsey and workflows. I think ultimately that standardizes the clinic so our therapists can go back and forth and ultimately helps with patient safety, right? We want y'all to be somewhat creative and troubleshoot, but we also want to make sure that we're following some standards ultimately to be safe for the patient. So we actually had the whole team collaborate and create workflows. And one of the things Elise started was having that ROI part of the therapist chart check. So you have dedicated time to draw it. It's not like on the fly, let me just slap something on. And that way they can customize that ROI for the patient. So I'll have Elise kind of talk about what we do for our weekly port patients using Vision RT.
Yes, so this is an example of our breast workflow. We start with the DICOM, get the deltas as close to 0 as possible, take that treatment capture, make any adjustments if necessary, rotate that gantry over to your medial field, check out the light field, make sure it's where it needs to be, check your SSD. If it's a step out, take your ports, everything looks great, you know, you're good for the next day. If your MV port does not look great, maybe start by adjusting that ROI. Or if the ROI does not work, we need to go back to KVs. And then ultimately, if you take your KVs, you're going to apply those shifts, and then you're going to take a reference capture. And then the next day, you're going to set up to that VRT, that reference capture, and then take a pre-port to make sure that the VRT is what you want to use and not the DICOM.
Yeah, and so at least what % of patients do you think you have to edit the ROI to make the system work?
Maybe 10, 15%.
Yeah, so very minimal because we've had the therapists kind of educated on drawing the ROI and really take their time in drawing that ROI. And then the other thing is we don't let them give up. Okay, if the system didn't work, and well, let's do a KV and then use a reference capture and use that system going forward. And we've seen probably majority of patients will be able to do that. So we're still using surface guiding every day. One of the things we talked about as a group as well, we have Align RT, and if we KV, which one do we prioritize, or which one trumps each other? So we said for doing imaging, that's going to trump Align RT, right? So that's why if we do a KV, take a reference capture to monitor for that day, and then set up to that going forward. And then we do verify that it's correct afterwards. So once we felt really comfortable with MV breasts or VRT breasts and MV weekly, we said, well, let's take the next leap of doing DIBH. So, how do you get this complex? How do you train someone in learning this complex treatment? Sure, a few of us went to Denver and was like, oh, this is doable. We've come to meetings, seen this, but how do you get the rest of the team to get that buy-in? So we actually had our dosimetrist set him to the gym a little bit so he looks a little bit better for the therapist. But he volunteered, took his shirt off, and at least we'll kind of explain the procedure we did with him.
So this is a team approach. So, our dosimetrist was great, volunteered for this. So to practice the DIBH, we made time in our schedule every day for about a week. And we laid him on the table, took a reference capture and a free breathing, coached him to take a breath in, took a reference capture. Then we lined up to that free breathing, swapped over to the breath hold, told him to take that breath in, and we just kind of practiced that workflow on him, and it worked really well.
Yeah, so every day he was scheduled on the treatment machine, so that way there wasn't an excuse that we ran busy or didn't have time for it, and he was great. He got on the table, did what he needed to do, but he actually learned that it's difficult to hold your breath for 20 seconds laying down. Despite him going to the gym every day. I'm glad I was not the volunteer. But, he came up with planning guidelines, and he said, well, maybe I can have the MLCs go different ways when we're doing field and field to speed up that delivery. And so we actually have the MLCs going from the inside out versus outside in to doing field and field. So that really helped him realize that this is a tough treatment for a patient. So let me see what I can do to shave a few seconds off from the planning perspective. One of the other things we did, and we have a daily morning meeting where we review the schedule, review the patients for the day, and see how the machines are doing for warm-up. So what we did is with the group, I wanted to show them why we're doing some of these extra steps. Ultimately, education and investment in the team is going to get you good buy-in. So I just took one of the patients and just showed them, this is free breathing, and just slide over to the DIBH. And you can see how that heart moves significantly with just a small breath in, okay? And so once the team saw this, they're like, hey, we're actually adding value to the patient's treatment. We're doing something good for the patient, right? And so once the team found that out, they're like, okay, we understand. Let's take a few more steps. Let's learn this technology so ultimately we can help the patient.
So here are just some pictures of our free breathing setup. We make sure that we are on our free breathing course. Play the monitoring field, get our deltas as close to 0 as possible, take that treatment capture, play it again before you hop over to the breath hold, and make sure your deltas are as close to 0 as possible. And this is the photos of the DIBH setup. So make sure you're on your DIBH. That's very important. As soon as you play it, you're going to know that it's obviously not going to be green because they're still in their free breathing state. Then change your magnitude to the coaching. So you'll have that coaching tool. You'll see the bar turn green whenever they're in their breath hold. Then you'll see on the what is that, the right side? Yeah. That the deltas are agreed in their breath hold state after being coached.
So coaching, practicing, and then we also want to check an SSD in their breath hold to make sure that the treatment's in the right position. So I think one of the things the team, we wanted to teach the team is, this breath hold from being out from free breathing, which is normal, right? They're not in that expanded position. Really getting them as close to 0 as possible at free breathing because that will get you to close to 0 for DIBH. And so one of the things I like about SGRT compared to using RPM block for DIBH is, we know that the system shows us that the patient's breathing in multiple directions. In this patient, there's a vert and a long that they're out in. And so to clean that up, by taking that breath in, they're going to go from the free breathing where they're green to the DIBH where they're green, right? And to hit that trajectory, that's going to be that same trajectory every day, right? And so if they're set up incorrectly to begin with, then when you ask them to take that breath in, they're going to be in the red and not going to be able to beam on. So very important how that free breathing position is important to have them as close to zero, because you're assuming that they're going to take that same breath daily. So sometimes what we've done is gone back when they've coached them, looks like it's working, they come out, they might have relaxed. So we go back to free breathing and say, let's clean up that error so that way we can't hit that DIBH daily. And so with our dosimetrists, just showing y'all some of the examples that we did. We got him on the table. He's in free breathing right now and asked him to take a breath in. He did okay. Well, kind of didn't do so well at the gym. Took a little bit more breath in and held it. So coaching him and the therapist practicing this every day really helped get everyone on board and says, hey, this is doable. Let's get a real patient on the table.
So we created our inspiration breath hold workflow here. It's real similar to our MV Weekly, set up using the DICOM first. Make sure you're on that free breathing. Get as close to zero as possible. Take those treatment captures. Rotate the gantry over to the medial field. Coach the patient into their breath hold. Eyeball that SSD. Check the light, the field light on their skin. If everything looks good, step out, take your ports. And we have a policy that our MD and physics team are at the console with us, that dry run day and treatment day 1 and treatment day 2.
Yeah, and I think that's important because, they do well in sim, they might do day 1. We want to make sure that they're consistent throughout that 4 weeks or 6 weeks of treatment. So actually being able to reproduce that setup, reproducing that breath hold for 3 days, makes us all feel confident that we're going to be good for the rest of the treatment. We actually, throughout our experience, we've only had 2 patients that haven't done well with DIBH. One was a patient that was just all over the place. She did great in sim, but then just couldn't breathe it or hold her breath at all, or was wiggling all over the place after taking a breath. So we said, okay, this patient's not a good patient. Second patient was someone that we were like, well, she's a great breather, very fit, very athletic. What's going on? Well, we realized she took a 1.5 centimeter expansion at sim, and she just couldn't reproduce that for daily treatment. So what we did is we took a step back in our workflow and introduced some steps into sim to make sure we can be successful on the machine.
Yeah, so the RPM that we use in SIM is great. It's a good tool to know that the patients are taking in that same breath every day. And we really explain to the patient that we don't want a big, deep inspiration to where they're arching their back or changing that pitch. We really just try to coach them into just taking in a normal inspiration and filling those lungs up with air and holding that right there. The deep breath is not necessary. It's just a regular inspiration and holding that. And coaching them in SIM is really, really important for the DIBH process. The RPM box, we were able to even make sure that they're not taking in a 1.5 centimeter breath hold. And we also make sure that they can hold that for at least 20 seconds.
And that video that we showed you earlier was between free breathing and breath hold where that heart moved away. That was only a 3 millimeter expansion. So just a small breath is probably enough to pull that heart away. Typically, most patients are 5 to 8 millimeters, but even a small breath like that can make a significant difference. So what we did is we said, okay, well, maybe we need to do some patient education. So we pulled in our nursing staff into the team and said, let's come up with some education for the patients. So, what is this? And we actually called it inspiration breath hold instead of deep inspiration breath hold because we wanted to be consistent. What is this? What is this technique? What does it mean for you? And really, you're really in control of your treatment. So if you lose that breath, cough, whatever, don't feel bad about over-radiating your heart. The beam's going to turn off, right? So they're really in control of the treatment. We kind of Google these images, so they're not our artwork, so that's one of y'all's artwork. Thank you. Everything was on Google. But really showing them when you take that breath in, don't arch your back, kind of educating them before they go into sim. And I think we've been very successful with that. And then the therapist really coaching the patient. And then they actually have homework assignments to do as well. So go home, practice this at home. Laying on your back and breathing and holding your breath is great. We don't want them to be a deep sea diver and hold their breath. We just want them to be able to hold their breath for 20 seconds. And of course, we can shorten those beams or stop the beam in between if someone's not the ideal patient. So we actually had a difficult patient and kind of wanted to make this interactive with the group before we get to SBRT lung. And so we had a patient recently who was Vietnamese, didn't speak any English, and had hearing aids. So I said, well, she's left breast. Let's get her husband into SIM, and he can coach her over the intercom, speaking Vietnamese. So I was like, let's evaluate her, right? Because every patient might not need DIBH. If you're young and you don't eat fast food like most of us do, you might have a small heart, not need to use it. And so we did a free breathing scan, said, oh, maybe she needs DIBH. He coached her, excellent. And so we thought over the next week or two, her husband would teach her, breathe in, breathe out, stop, go, red, green, something to help with those commands, teach her a little bit of English. We were fortunate to have a Vietnamese nurse, so she was calling her over the phone, teaching her, when you hear this, when you hear that, this is what you need to do. So she came into treatment. And
for a dry run day. And yeah, that didn't work. She, even with, the Vietnamese nurse in there translating for us, she was still struggling in the room with those commands. So we had to come up with a solution because we know that this patient really needed this breath hold treatment and that she would really benefit from it. So we had to come up with a solution to treat this patient so where she could understand and follow the commands. So
and we didn't have the real-time coach. That would have helped, right? Solve the problem because she could see red versus green. We didn't have one at Kelsey, or we don't have one at Kelsey. Hopefully we'll get one. So we wanted to come up with a solution to treat her because we need to definitely treat her. So we'll ask the audience, what are 2 words that every person should know in English? Any guesses? Huh? Yes and no does not work. In and out? Nope. Good, bad, she did not understand. We tried a lot of different things. Hello, goodbye. Well, we didn't try that one, but that did not work. So I was actually looking at the treatment monitor in the room, and I saw her first and last name, and I was like, she has to know her first and last name. Hopefully, in English.
Yeah. So we actually used her first and last name for the commands. Our Vietnamese nurse told her that when we say her last name, that was the command to take that breath in and hold. When we say her first name, she could breathe. And that worked so well. She did so good. She has been our best patient so far with this DIBH program. Yeah, she did amazing.
So we didn't let the group give up. I did get some rolling of the eyes.
He didn't let us give up.
Some shaking the heads of, can we go back to free breathing? But we said, if the patient needs it, let's try it. Ultimately, we can always adjust the blocks and block the heart away. So the team approach, so getting everyone involved. So, initially we started with using SBRT just for monitoring. We updated our workflow to using it for setup, and that really helped minimizing any shifts we do. We actually have a 60 couch on the edge side. We take a reference capture once we're in the treatment position, take some KVs to ensure that cone beam shifts were correct, and then we use SGRT to gate the beam. We actually use fluoro. We have advanced imaging on our machines, so we can fluoro the patient, and we identify that the ITV in SIM is truly the ITV for our treatment. We don't do breath hold for our lung patients unless, we don't at all, but most of them are not very mobile tumors. We also think some of these patients have poor lung function to begin with, so asking them to do a breath hold is somewhat difficult. So we use them for setup monitoring and getting the beam. For our radiosurgery patients, and Elise will tell you this is probably not the ideal mask.
Not very good.
But we had a photo shoot, so we actually made this on one of our staff members. And so
this is better.
This is better. So we use the Encompass masking system. We really like it because you can shim down the patient in different areas. Open face mask as well. Patients have had good experience in it. And like we talked about, you want to include certain areas of region of interest, but also, it's patient specific. If you have that very full eyebrows that are pointing out at you and moving around, probably not the ideal area to keep in your ROI. Mm-hmm. So we use it for setup, monitoring, and gating for our radiosurgery patients.
So you notice we take the eyes out too, because when their eyes are opening and shutting, that can cause some jumpy deltas.
So we set up the patient we tighten down the mask 1 notch just to make sure that they're definitely fixed. We use SGRT to improve the setup, do 6D couch, cone beam, take a reference capture, take KVs to ensure that we're in the right position and that they haven't moved since the couch shift. And we've seen a great correlation to SGRT. Patient relaxes, has sinus drainage, fell asleep, but you go in to kick the couch to a different angle, and they wake up and they get startled. So we've seen, of course, everything's probably sub-millimeter, but if it stays sub-millimeter and off to the side, sometimes we'll go back and recomb beam the patient. But we feel very comfortable in the system. The team trusts the system. Recently, we had a therapist from another center with 15 plus years of experience where they don't have SGRT, and she saw a patient actually move using SGRT between couch kicks. And when we did the cone beam CT, it was identical to what the SGRT system told us. So she felt comfortable her second week, and she's like, wow, this system really works. And we weren't even training her on the system at that time. She was just learning some of the fundamental workflows. So we don't re-image between couch kicks. We do re-image between ISIS centers, but we know that the system, we feel comfortable. Sometimes you might have a camera blocked out if you're at 90, but we do a dry run and say, okay, things look good. When we get to this angle, we're going to be out, and then we come back down. If we ever feel like the patient's moved, bring them back to zero, gantry zero, and we prove that the patient hasn't moved, then we'll feel comfortable opening up that the threshold if needed. So a lot of values and applications of SGRT. We talked about daily setup, and Elise can definitely tell you it's improved their workflows.
Yes. We've improved the workflow tremendously with the AlignRT software, decreased our setup times in the room, having to go in and out of the room to reposition the patient, definitely decreased the imaging exposure to patients. We're able to do the DIBH, and monitoring the gating just ensures us that we are treating that patient accurately throughout the whole treatment. And patient safety, of course, we're
following those national guidelines, not needing to image every day. And then nice thing is some of the tools in SGRT, AlignRT can check your daily SSD.
And the surface stats, one of the tools on there, you're able to see if the skin or the tissue has changed any at all using those surface stats. So that's also another good feature that we're able to use.
So showing you some case examples outside of some of the examples we've shown earlier. This is a patient with a chest wall, patient who had expander in place initially at treatment, treated her for multiple days, and the AlignRT system actually said, hey, this patient's not setting up for whatever reason. And we're like, well, what's going on? You know, she's where she needs to be. And then we looked at her setup photos and said, hey, that mound where she had that expander has deflated, you know. And so if we're doing weekly imaging, we might have missed that. But we were doing weekly imaging, but AlignRT actually found that for us. So we actually have advanced imaging on our Linac, so we did it on-demand cone beam CT and showed, hey, yeah, that expander has deflated. So we sent her to plastic surgery. They said, expander looks okay, so we ended up replanting her. But we could have gone multiple treatments treating her incorrectly with that expander deflated. You know, occasionally we have very long fields. This is a lung patient that we treated just maybe a month or two ago. Very long field, goes from basically from the clavicular head all the way down past the heart. Very large disease, and I think this is another indication for SGRT. You know, some either extended fields in the chest, or if you're doing a periaortic pelvic field. You know, one for setup and also monitoring the patient. This patient also had some couch kicks. We'd like to do couch kicks for these long fields to minimize dose to the lungs rather than going all the way through the lungs for most of the dose. But you can see here that if you just image the patient, let's see if it works. So if you set them up, this patient was set up just with tattoos, and if you just image the patient, they can be all over the place. So they have a lot of pitch, they have roll, and none of the contours are really matching up. And the other thing is you're not cone beaming that whole volume that you want to cone beam, right? Sure, you can stitch multiple cone beams together now on some of these newer Linacs, but you're not really using that reference to where you need to be. So probably my fault, I forgot to put it in the prescription. So luckily our dosimetry team exports all of our patients to AlignRT, so they were able to, you know, while the patient's in the room, draw a quick reference. We turned it on. They were like, oh, it's not working. Well, we had to take the sheet off the patient, right? Because the patient had a sheet on him. And what we did is they were able to set up the patient perfectly. And when they cone beamed, we felt very comfortable. So this 30-minute setup of struggling that first day ended up being 5-minute daily setup and getting the patient exactly where we need them to be.
So with our bilateral breast patients, the Line RT decreased the treatment time tremendously. We just have a lateral shift between our right and left breast. We were able to remove our KVs, and our ROIs, we focused on the entire chest, all the way over to the lateral aspect, and they set up great with the Line RT, and we are able to decrease that table time for the patient and make it so much easier for her laying there with her arms up.
So rather than just focusing on one side and then switching your ROI to the other side, sometimes you might have had to move the patient in between. So make sure they're set up perfectly for both treatments, and then you can just lat them over. Prior to at least coming here, we had just opened the clinic. We had all these nice, immobilization devices, and I've never used an aquaplastic extremity device, but the therapists were like, "Oh, let's start using this." So we did it on this patient who had a leg sarcoma. We didn't sim them with that tape on, but there was some flexion or extension of the foot at sim. Pretty easy field. It's just obliques, nothing too fancy. But when we got to treatment and we took the images on day one, we're like, "Hey, that foot is in a different position, and we might be missing that volume." So the therapists were like, "Hey, we know we have a Line RT. Maybe we can draw that volume in, and we can make sure that that extension or flexion is in the right place, tape that down, and immobilize the patient properly." So not too excited about Aquaplast for extremities, but in case you do use one, this might be a way to overcome a setup issue.
We also had a difficult thigh sarcoma that would not set up. Despite having, the level marks, straightening marks, he was just really difficult. So we were able to use the Line RT to fix the pitch and the roll and get him exactly where he needed to be prior to the cone beam.
And so this has become our standard for every extremity patients using a Line RT to set them up, less back and forth in and out of the room. Once in a while we'll help the therapists when we're short and treating, and I know I don't want to be walking in and out of the room so often, so we try to minimize their back and forth, minimize their exposure. We treat most of our prostates prone with a rectal balloon. I know some patients do supine with a rectal balloon. I just think it's easier to pop it in with them facing downwards, and not falling over. This is how I was trained, so we kept it that way. So sometimes you'll have pitch and roll issues. I know it's not the most exciting thing to see someone's behind on a screen, but it really helped us set up these patients. So really great for prone patients as well. I think they talked about a prone breast earlier. We don't do prone breast, but I think you use those same concepts to help set up patients. So this patient had a lot of pitch, a lot of roll. Using the system improved that and really got them into the treatment position rather than cone beaming them multiple times. So as you've heard today, I think SGRT has really helped our clinic, not just in workflow, minimizing exposure to the patient from a radiation standpoint from imaging. I think the therapists have bought into the system. Even though we've had the system for 4 years, we really didn't implement any of this for the last year and a half. Really took us a few weeks to get comfortable with the system, getting everyone on board. And some of it was challenges that we kind of said, get everyone involved and really have that team involved. And I think that's really helped us.
Yeah, and you not giving up on us and supporting us and making us use the system.
Absolutely. So, I encourage everyone to, see if they can get their whole team involved back home. And I think that will definitely help you leapfrog and come over some of the challenges that we've heard over the last day or two of how to really get the technology implemented. Ultimately, it's just helping the patients, and that's what we're all here for.